Good morning and welcome to this Downing Street briefing, which this morning is a technical briefing about coronavirus vaccines. I'm Jonathan Van Tam, Deputy Chief Medical Officer, Department of Health and Social Care, and I'm delighted to be joined this morning by, first of all, on my left, Dr June Raine, who's Chief Executive at the Medicines and Healthcare Regulatory Agency, the MHRA, our UK regulator, and Professor Wei Shen Lim from Nottingham University Hospitals, consultant physician and chair of the Joint Committee on Vaccination and Immunisation, COVID-19 Vaccines Subcommittee. So both very key and very important individuals in our preparations for COVID-19 vaccines. And welcome to you both, and I'm delighted to have you. I'm going to start with my own short briefing using some slides. So the first slide I'm showing you is the traditional vaccine development sequence and timeline for a vaccine in peacetime, if you like. There are, first of all, the red boxes, which are design and process development stages. And finally, one gets to the point where it is time to do clinical trials in humans. And these pass sequentially through phase 1, which are small studies. They are focusing on initial safety and they are focusing on dosage. Phase 2 studies, which follow, which focus on determining whether vaccines can generate an immune response. And by that, I mean can elicit antibodies in humans. Those phase 2 studies are not so small, they are medium-sized. And if successful, companies then move on to phase 3, which are trials in the real world, if you like, where what we are looking for is a signal that the vaccines not only generate antibodies, as we've seen in phase 2, but also protect people from real-life disease that's out there, from disease. And those trials are very big indeed. And typically for the vaccine studies in the COVID arena, these studies are 30 to 50,000 individuals per phase 3 trial. They're very large. Safety assessment actually takes place in all of those clinical trials, all the way through. And then if you're successful at every stage, and there's often a decision point in between stages within a company, there is a regulatory filing, and the regulator in a given country, in our case the MHRA, then performs a review. And only after that has been done can there be large-scale production and distribution. That's the normal peacetime route to bringing a vaccine into human use. Next slide, please. But in the case of the COVID-19 pandemic, everyone knows that this is a public health emergency, and we are in a much more difficult position. But as you can see, there's some slight variations on how the clinical trials are put together. There are still the design and the process stages. There still has to be a clinical trial authorization, and there still has to be phase 1, phase 2, and phase 3 studies. They are no smaller just because this is a public health emergency. The standards are no lower just because this is a public health emergency. And the phase 3 trials are still very big. Where the differences are, and I hope you can see these on the slide, is first of all that the trials overlap. Companies and governments make decisions to move on to the next phase whilst just completing the last phases of the previous trial. So phase 1 and phase 2 and phase 3 have been brought closer together and overlapping, but they haven't changed in terms of size and reach. And the data from each of those phases individually can go forwards to the regulator in terms of a rolling regulatory review. In other words, the regulator can start to look at things earlier than they would normally do. And the companies have made decisions to begin large-scale production at risk. By at risk, I mean at risk to them, that if their product then doesn't make it through phase 3 trials, they'll have to literally destroy all that they've made. They can't use it. But they've recognised the public health emergency and have been prepared to make those kind of investment decisions in the hope that the trials will be successful. And that's really the big differences between where we are traditionally with vaccines and where we are now with COVID-19. I'm now going to pass over to Dr Raine to tell you a little bit more about how vaccines are regulated and authorised for human use. June.
Thank you. The Medicines and Healthcare Products Regulatory Agency is the UK's independent regulator. Our role is to ensure that medicines and devices and vaccines work and are safe for use. The safety of the public will always come first. A COVID-19 vaccine will only be approved once it has met robust standards of effectiveness, safety and quality, right through the tests and the trials. For us, for the MHRA to approve a vaccine, how do we approach this? Our teams of scientists and clinicians carefully, methodically, scientifically, rigorously review all the data on safety, effectiveness and quality. And we ask questions: what does the vaccine contain? How does it work in the body? What level of protection does it provide? And the data we look at include all the results from the laboratory studies, the clinical trials, the manufacturing and quality controls, and testing the product. Our independent National Institute for Biological Standards and Control does that. So public can be very confident that all those tests are done to the very highest standards. Since this is a national emergency, you have seen that we undertake a rolling review in real time, looking at the packages of data as soon as they become available. And that means that the final decision on the balance of benefit and risk can be taken in the shortest time possible. We go one step further and we consult our national expert advisory body, the Commission on Human Medicines, and this will also critically review the data using its expert working group, which has been set up including a wide range of disciplines: immunology, vaccinology, clinical pharmacology and epidemiology, to name a few. So that will be the really robust process that the public and patients can have confidence in. Our work doesn't stop there though. Once the vaccine is deployed, we have a range of tools and methodologies to continually monitor benefit risk in clinical use. The tried and trusted yellow card scheme is a way in which everyone can report. So in a nutshell, our job is to work to the highest possible standards, to work independently, and safety is our watchword.
Thank you very much, Dr Raine. And I'll come back in at this point and then say that there are lots of different types of COVID-19 vaccines in development. On the next slide, you can see the types of vaccines where the UK has an agreement with one or more companies for a supply to a total of 350 million doses if all of those products and trials were to work. But many of them are still in development or phase 3 trials, and we don't know the results yet, and we don't know the outcomes from the independent regulatory processes. So just to give you some flavour of the kind of vaccines that potentially may come through over the next year or so, there are the messenger RNA vaccines. That was the subject of the Pfizer announcement on Monday. These vaccines essentially send a coded message to the immune system to tell it to make COVID antibodies. There are the adenoviral vector vaccines. These insert the COVID spike protein. That's the key antigen, the key protein which allows humans to recognize the virus and allows the virus to bind with the human cell. Those are inserted into a harmless or weakened common cold virus, and that again stimulates antibody production. Then there are the protein adjuvants, protein adjuvanted vaccines. These are slightly older technology, and they are effectively pieces of the COVID virus protein broken up, and when given with an adjuvant, they stimulate antibody production. And then finally, there is the option of a whole virus approach, which is where you take the virus and you kill it. And then it is safely injectable and it stimulates antibody production. So there are many different approaches, many different manufacturers, and we're just at the beginning of this journey. And it is that complexity of what we hope we'll have soon versus what we hope we'll have within 9 to 12 months that makes the job of the Joint Committee on Vaccination and Immunisation very challenging indeed, but a terribly important job in terms of then determining, after authorisation, who should receive the vaccine. And Professor Lim is here to explain to you some more about that.
Thank you very much. As Jonathan says, the Joint Committee on Vaccination and Immunisation, JCVI, is an independent expert committee, and we're constituted to advise the Secretary of State on the provision of vaccination and immunization. During this pandemic, we've been meeting weekly recently to appraise ourselves of all the available scientific information that is relevant and to be able to make the best possible recommendation in the most timely manner. This is all on an independent basis. I just want to describe the current interim recommendation from JCVI regarding the priority groups for vaccination when a COVID vaccine becomes available. The current phase that we would suggest or recommend is a phase where we prioritize the most vulnerable individuals in society, specifically people who are most likely to die from severe COVID-19 infection. And we take into account the important role of the NHS and social care as well. A further consideration in our prioritization is that the program needs to be recognizable, it needs to be understandable to everybody, and importantly, it needs to be deliverable. We've reviewed data on how the pandemic is progressing in the UK, the risk factors that are associated with severe disease from COVID-19, and mathematical models that have looked at different vaccination strategies and how those might work. I'll just come on to the priority groups as they are defined at the moment, and I just want to underline that these are interim current recommendations and they may change as we get more information. At the very top of our priority list are care home residents and people who work in care homes. This reflects the devastating impact of COVID-19 in our care homes, as we all know. Following on from care home residents, we will prioritize older individuals, going down age bands, down from 80-plus-year-olds to 60-plus-year-olds. And the reason for this is because age is by far the strongest risk factor associated with severe COVID-19 disease. Following on from those who are age 65 and above, we will then prioritize individuals, particularly adults, I should say, who have an underlying health condition that puts them at risk of COVID-19 disease. Following on from there, we will keep going down the age bands to individuals who are 50 years and above. That describes phase 1 of the program, and phase 1, as I say, is aimed at protecting the most vulnerable. If phase 1 is completed, then we will have protected, hopefully, over 99% of those individuals who are at risk of dying from COVID-19. We have not decided yet on who else should be vaccinated beyond phase 1. That's not to say that they shouldn't be vaccinated, but simply that we haven't decided yet on prioritization. And that's because we need more information, hopefully, on the vaccines, who they are good for, and whether they protect against transmission or infection. So these other recommendations will come in due course.
Thank you, Wei Shen. So that concludes our opening remarks from the table. I think we now have questions Fergus Walsh is first. Just to remind all colleagues joining via Zoom or Teams that we do have a hard stop today at 10:45 because of the remembrance observance, and therefore we have to move at reasonable pace through these questions, and I hope you'll forgive us if we do that. Fergus, please.
Yeah, question to Dr. Raine. Some people might be concerned that authorization might be rushed of COVID vaccines. Can you reassure people that safety won't be compromised? And to Professor Van Tam, do you think it might be a good idea if the Prime Minister and people like yourself were first in the queue for a COVID vaccine, and that might be a mark of confidence in a COVID vaccine?
June.
Thank you. This is a critically important point. Although we have adapted our processes to undertake our rigorous review of effectiveness and safety in a rolling way, there is absolutely no chance that we will compromise on standards of safety or effectiveness. And the steps that help to reassure on that include our independent expert advisory committee, which is an even greater layer of independence.
And so the question was, Fergus, would I be prepared to have it? So I'm a 56-year-old with one, I think Wei Shen would say, medium to high risk condition. If I could, rightly and morally, be at the very front of the queue, then I would do so, because I absolutely trust the judgment of the MHRA on safety and efficacy. But that clearly isn't right. We have to target the most highest risk individuals in society, and that is how it should be in terms of our system. But if I could be at the front of the queue, then I would be. Let me say to you this, I think the mum test is very important here. My mum is 78, she'll be 79 shortly, and I've already said to her, Mum, make sure when you're called you're ready. Be ready to take this up. This is really important for you because of your age, and just be ready to be called. I hope that helps. Thank you, Fergus. Emily Morgan from ITV.
Hello. Biotech told us yesterday that if we don't fulfill our order quickly or in a timely manner, the doses will go elsewhere to other countries. So any delay, obviously, in improving the vaccine could obviously jeopardize our supply. So I just wondered whether you are preparing to supply the vaccine before it is licensed. And also, if I may, I just wondered when you think phase 1 of your implementation could be finished. Okay,
thank you. So the commercial details of how we've placed the order with Pfizer-BioNTech are a matter that the Vaccine Task Force has been dealing with. We do have the option to order up to 40 million doses. We will not use anything until the MHRA has made its adjudication on safety and effectiveness. Do I think we will then move at pace to keep up with the volumes that are supplied to us? Yes, I absolutely do. And the Secretary of State has, I know, he's set a challenge to the NHS that the only rate limiting step for how quickly we can deliver vaccine to these high-risk groups, which the JCVI has identified, should be the rate at which the vaccine can be produced and delivered to us, not the speed at which the NHS can deliver. And on that point, remember that the NHS does an astonishing job in terms of vaccinating essentially the same kind of population groups against flu every September, October, November. And this year, uptake is really high and moving very fast indeed. And from that perspective, I have every confidence that this system knows how important vaccinations are, knows how important COVID-19 vaccines are, and will move at the required speed. Next question, please. Thomas Moore from Sky.
Thank you very much. Professor Van Tam, a vaccine that's 90% effective still leaves 10% vulnerable to disease. 532 people died yesterday. 10% may still have died even if all had had the vaccine. Can we return to normal by Easter, as some have suggested, if 53 people a day are still dying from COVID? And can I also ask Professor Wei Shen Lim, it looks like lots of people under 50 who may well be at low risk of death, but still face potentially lifelong debilitating effects of long COVID, won't get the vaccine in the first phase. What circumstances would they receive a vaccine which, as we now know, is 90% effective?
Thanks, Thomas. How soon are we going to return to normal, and what role will vaccines play in that? At this point, I don't think those questions can be answered. We don't yet know what the programmatic effect of rolling out the vaccine to the high-risk groups that Wei Shen has outlined will be. That will take time for those effects to be seen. Delivery is not going to be instant across all of those groups. Vaccine production is not going to be instant across all of those groups. We don't yet know if this vaccine is going to prevent transmission as well as preventing illness. And from that perspective, it would be wrong of me to give you a sense that whoever told you that we'll be completely back to normal by Easter is right. I don't think I know the answer to that. I think I can tell you that I'm very hopeful that over time, vaccines will make a very important difference to how we have to live with COVID-19 in the long run. But as I said on Monday at the Prime Minister's briefing, will these vaccines be a get-out clause for the current second wave that we are in? Absolutely not. And we're going to have to push this second wave down by the non-pharmaceutical interventions, the social distancing, the stay at home, all the things that we're doing right now. There's no shortcut to the future you and I both aspire to. Wei Shen.
Thank you. I have friends and colleagues whom I personally know who have had COVID and unfortunately are still suffering from the longer term effects of COVID. So I'm well aware of how important that is. In phase 2 of the program, it's likely that we will prioritize individuals who may suffer because of the need for hospitalization because of COVID or perhaps because of long COVID. But that hasn't been decided yet. And the reason it's not been decided is because we need to also balance the possible prioritization of individuals who might be transmitting COVID instead. So that's a different model or different strategy, if you will. And until we have enough data, it's difficult to balance these two appropriately. So the information will come, we're just not there yet.
Thank you. Victoria MacDonald, you're next from Channel 4.
Thank you very much. As with the flu vaccines, will people be able to jump the vaccine queue and buy this vaccine privately? And also, how confident are you about any of the vaccines in development having been tested adequately on the older age group?
Okay, so the first question was about queue jumping and in terms of kind of private paid for access. I'm a doctor. I've worked for or around the NHS for most of my career. One of the things I like about the NHS is that it's there for everybody, irrespective of their level of wealth or who they are in society. That is a really, really important principle to me personally. And I think everyone understands that these are commodities that are going to be needed to be used for public health purposes in the first instance. And I don't know of any plans from any manufacturers, and certainly don't have any inkling that we would contemplate that kind of arrangement for the UK. Though, of course, that is a ministerial decision. It is not a clinician's decision. I'm giving you my views as a clinician that I think these vaccines need to be prioritised to those who need them, not those who can afford to pay for them privately. Did you ask another further question?
I did, and thank you for that answer. There has been a discussion around how different older people's immune systems are and how they react differently to vaccines. And I just wondered, because we've had no detail from the Pfizer-BioNTech vaccine on who they've tested it on, or on the other trials. I just wondered what you know about this.
Right. So I certainly know that all of the companies developing COVID-19 vaccines, including Pfizer-BioNTech, are very, very sensitised to the fact that we will want to give these vaccines, not just in the UK, but frankly right across Europe. I was on a call with many European countries the other day, and they're having the same approach as we are, essentially, that we will need to give these vaccines to older people. And it is a first immunological principle that sometimes vaccines do not work as well in the elderly as they do in younger adults. And I know that all the companies are focused on making sure they have adequate data and an adequate readout on how the vaccines work in older people. What I've seen of immunogenicity, that is the ability to create antibodies, is that the vaccines I've seen data on, and these are in the public domain, these papers, show good responses in the elderly. But that's a matter which the MHRA, I'm sure, will look at, and I'm sure which JCVI will take into account. I don't know if you'd like to add any further comments on that.
I would like to reassure you that we will look extremely carefully at effectiveness and safety in older people, and it will be certainly one of the central issues our independent expert advisory committee, the Commission on Human Medicines, will be looking at and advising on.
Wei Shen, anything to add?
Yes, I would like to just mention a point that June has raised. Because vaccines may act differently in older people, that may, of course, impact on how we prioritize the use of vaccines. And as new vaccines come available, we may prioritize vaccines differently for different people.
Thank you for the question, Victoria. We're now moving to Tom Whipple at the Times.
Hi, thank you very much indeed. I'd like to ask, what does 40 million doses mean? We've been told that this is what we've pre-ordered. Does this, to put it crudely, put us ahead of other countries? Do we have an idea of, if we said yes tomorrow, how many of these doses would be with us when? And secondly, we haven't seen the Pfizer data in any detail yet to see who the 94 infected are and you know what age categories they fall into. Have you guys? Has this data come over yet?
Right, so the very simple answer from me to your second question is no. I've only seen the data from Pfizer that are from their earlier studies that have been published either on preprint or in peer-reviewed journals. I haven't seen any data that you haven't seen, actually. I would expect the first people to see that will be the regulator, the MHRA. And on quantities, I'm not aware that Pfizer-BioNTech are publicising the individual contracts they might have, certainly not publicising to us the different contracts they might have with other governments. I can say that we have an agreement for 40 million doses in total, which will cover 2 doses per person for 20 million citizens, and that we are working with that company to understand what the volumes of delivery over time will look like. Pfizer have said that they expect to be able to make a total of 50 million doses this year, and obviously a lot more in 2021. June, would you like to comment on the data point at all?
I can confirm that we have started our rolling review on quality data, but we have not had yet the full clinical trial data that you are talking about. And clearly we're in a state of readiness to start our rigorous reviews of safety and effectiveness the minute that reaches us.
Thank you, Tom. Sarah Bosley at The Guardian.
Thank you very much for taking my question. The Pfizer-BioNTech vaccine that everybody's got very excited about is said to be 90% efficacious from the interim results. But what if the Oxford-AstraZeneca vaccine that we expect to come along, which we've actually bought a lot more of, turns out to be, say, 50%, substantially lower? Could we see a scenario actually where populations here or around the world think they're getting an inferior vaccine? And also, could I ask Professor Wei Shen Lim, will there be any priority for vaccination of Black, Asian and minority ethnic communities, given that we think they have been worse affected?
Thank you, Sarah. I think most of the question is a question for Professor Lim to answer, but on the 90% point, that is an interim point estimate of effectiveness based upon the first cut of the data in the Pfizer-BioNTech phase 3 trial. And I'm searching through my notes for the Pfizer press release, but I'm absolutely certain that they intend to go on to 164 confirmed cases before they complete the trial. So the point I'm trying to make to you is that the 90% is a first estimate of effectiveness. That could change up, it could change down by the time the final results from the trial are in. And I think it'll be like that with all of the vaccines, that they'll do this interim readout. It'll give us a sense of how effective these vaccines are. But we won't have any finalised figures for quite some time, and we'll want to be delivering them long before we have those absolutely final data, which to my mind might well be as late as summer next year. Wei Shen.
Thank you. We've been focused quite a lot on vaccines and how we might give the vaccine, which is not surprising given the press release from Pfizer. But I'd just like to turn that round a moment. As a clinician, my concern are people and who are the most vulnerable. And ultimately, what we probably want to see from JCVI are recommendations saying for a particular group of people, what vaccines are most suitable. And so for maybe the older people group, which vaccines would we recommend? And there might be a preference in terms of the order of the vaccines that might be better for certain peoples. So that's the way I probably like to look at the problem rather than focus on the vaccine and how we might use the vaccine. On your second question, which is about prioritization of Black, Asian, and minority ethnic groups, that's really, really important. We know that there has been a disproportionate representation of Black, Asian, and minority ethnic groups for severe COVID disease. And the underlying factors behind that association are complex and they are multiple. They include social factors and societal factors, some of which, for example, are occupations. We know there are more Black, Asian, and minority ethnic groups represented in healthcare and in social care, for instance. There are differences in the amount of health conditions that some ethnic groups have. There are differences in terms of households, how big households are, whether they are multi-generational households or not. There are differences in access to healthcare. A lot of these social and societal factors also describe health inequalities. And one of the opportunities we should take with this vaccination program is to try and mitigate these health inequalities. That's done not simply by prioritization, but by tailoring our implementation in such a way that every patient group or people group are able to have access to vaccines to the best advantage. That may mean we have special implementation programs delivered by local community leaders who understand their communities, can engage with communities, can communicate in the correct way, can make sure that nobody has poor access to vaccines, perhaps by having flexible modes of delivery. But all of these processes, in terms of implementation, will help reduce health inequalities, which is by far a real important point that has been raised by the COVID pandemic.
Thanks, Wei Shen. So, Sarah, I'm going to come back in and say, look, on the point about, A versus B, well, I want A or I don't want A and I want B and I don't want B, you could be making a decision based on interim estimates of vaccine effectiveness rather than final ones. And the big win for us as a society, as a collection of individuals living together, is that we need speed of delivery and we need very high uptake in the groups that Wei Shen is picking out as being the most at risk of dying or having complicated disease. So it's speed and also high uptake that are important. And I think in this space, we've got to understand that it would be very easy to let the perfect become the enemy of the good here. Thank you. Kate Pickle from the Mail.
Hello there.
Hello.
Hi, there are reports that you're aiming to vaccinate around 1 million people a week. Matt Hancock himself has said this is a mammoth logistical challenge. And with the difficulties that we've already seen with PPE, for example, how confident are you that this will go smoothly? And also, how confident are you that this can be delivered without another impact on GP services?
You're quite right. It's a mammoth challenge. The point I've just made to Sarah Bosley was that we need speed and high uptake to get the big win here. The NHS will be giving journalists and the public a proper briefing on their plans for rollout at speed next week. So I'm not going to steal their thunder by getting into the details. What I can say, picking up some remarks I've already made, that you would instinctively, if you didn't understand just how many months people have been thinking about this for, you would instinctively have worries about, do we have the refrigeration type and capacity required? Do we have the transport systems required to move vaccine around? Do we have the needles and syringes to do this programme at speed and pace? The answer to which is, I am very reassured on all of those points. And an absolute army of people have been working on this for months behind the scenes, quietly, well away from media attention, but working at this at quite some speed. And the models that we will need to deliver that high volume, high impact vaccination programme will have to be innovative. So there will be some form of mass vaccination approach. There will be some form of mobile pop-up vaccination centres. There will be the standard methods of delivery that we see and that work successfully every year for flu. And there will also have to be some domiciliary and home visits for the extremely frail and housebound. And those models will have to be combined together, and people will have to kind of work intelligently based on the community that they're serving. And that's going to be very, very different in rural Lincolnshire than it is in a big inner city centre in Nottingham or Birmingham, for example. So those are all things that the NHS has a very firm grip of. And the Secretary of State has set this challenge that the one thing that should slow us down in this space is when we can get the deliveries of the vaccines that are authorised, not whether we can mount the response to get those to people who need them in accordance with that priority ordering that you've already heard about. Thank you, Kate. Finally, it's Nick McDermott at The Sun.
Good morning.
Good morning.
Sorry, a slightly leading question following up on the numbers, but on the flu vaccination programme, we're going at record speed and the NHS is delivering about 150,000 plus flu vaccines a day. To vaccinate the same number of people for COVID, we need 2 vaccines, so that would be 300,000 a day to go at the same rate. How confident are you, Professor Van Tam, that that could be done if we had enough stock? And can you give us a rough timescale of how long phase 1 would take in a perfect world? And just a quick question for Dr. Raine. Lots of focus on Pfizer, but we don't have the full set of results. And actually, coming over the hill, we may well have the full AstraZeneca results, which is the Oxford-made jab. Is there a chance, and how good is it, that actually AstraZeneca may pip Pfizer to the post and we may start vaccinating with that first?
Nick, thanks. I'll take the first bit of the question. I understand that people are doing lots of kind of, homegrown or kitchen mathematics on how this can be done and how it can be scaled up and what would be required. I am going to fend off your question and say that the NHS will answer that properly next week, but I am nevertheless absolutely convinced that the enormous NHS team behind this has grasped the nettle and understands the scale and challenge of the project and is up for it. And if you think about, the British Medical Association, of which I'm a member, the BMA has said that, very, very strong supportive things in the last few days about how seriously it takes this and how it will require a mobilisation effort to do this. But I think healthcare professionals get that, and I think they completely understand that this is one of the most important, if not the most important, vaccination programme we have done for decades. And from that perspective, if I don't mind telling you that I've had the conversation at home that if I can help with this in some evenings and weekends, doing some extra vaccination sessions myself, then I'm going to. And that's a given if I can get on the list and be useful. And I think people are approaching this with exactly that attitude. June.
You've asked whether another vaccine might pip the post, take over the lead. We've heard such encouraging results this week. What I would like to say, I can't predict these things. We haven't actually got to that clinical review yet. But the same high standards of safety, of effectiveness, of quality will be adhered to by the MHRA, whatever vaccine candidate comes to us. There is a question, perhaps in your mind, how can we handle multiple? This would be a great position to be in. And I can assure you that we have scaled up with teams, not just of scientists and clinicians, but our capacity to undertake the inspections and to fulfill the requirements for releasing batches. So we're at the ready. No one's going to predict the future at this point, but the same high standards of safety, of effectiveness and quality will apply whatever vaccine candidate comes to us.
Thank you. June, any final remarks that you'd like to make before I close the conference?
I think simply to say to the viewers that this is an enormous public health step that we're taking now, hugely encouraged by the data that are coming through, and that the regulator, who's independent from government, will be taking every step to make sure that we conduct our review in the shortest time, but to the same high standards. Thank you.
Thank you. Wei Shen, anything to add?
I probably want to say roughly the same thing and say that JCVI is in a process of reviewing all the information regularly, and we are independent, and we will make our recommendations to Secretary of State in a timely manner as required.
Thank you. Thank you both for joining me and for being so helpful with answering the questions. I hope that's been useful. This briefing is now closed.